Hey everybody. So I'm making a short video on basics of MRI, as is relevant for neuroanesthetists, especially the people who are just starting out, and they don't know what each of the MRI sequences mean. Okay, so let's start with a bit of the basics about MRI. So what exactly is MRI? It's magnetic resonance imaging. So how it works is that when the patient is put into the MRI gantry, that's the tunnel. Okay, that tunnel is basically quite a powerful magnet. Okay, so the Teslas, you must have heard 7 Tesla, 3 Tesla, 1.5 Tesla. So that is basically the strength of the magnetic field, which is always on. Okay, so as soon as the patient goes into the gantry, the entirety of the patient's protons inside the body, okay, so each of the hydrogen atoms, they all align to the magnetic field. Okay, so they either get aligned with the magnetic field or against the magnetic field. Okay, so now let's understand what that exactly means. Okay, so you have got a proton. Proton is basically one hydrogen atom. Okay, so atom has one positive charge and a negative charge which is going around it. Okay, so now this negative charge which is going around it, okay, that basically generates its own electrical field. Okay, so the electrical field is generated by the movement of the electron around the proton. Okay, and now this electrical field comes with its own magnetic field, which is basically by the, I think it was the Faraday's law or Coulomb's law, Faraday's law, I think. So basically the electrical field has a perpendicular magnetic field associated with it. Now this magnetic field, okay, that basically is not constant. Okay, so the magnetic field can change based on the surrounding magnetic conditions and as well as the body composition. Okay, so all of the magnetic fields of the protons inside the body are normally in a very haphazard type of fashion. Okay, as soon as they go into the gantry, they either get aligned with or they get aligned against the magnetic field of the MRI machine. Okay, now this vector, the vector of the magnetic field is not constant. Okay, it keeps moving. Okay, so this movement happens around an axis. Okay, so this movement around the axis is a spin, basically, you can say. Basically, the magnetic field itself is also spinning. The vector is spinning. Okay, now what happens inside the MRI when the sequences are initiated, what happens is that the patient is bombarded. These protons are bombarded with radio frequency waves. Okay, so these are basically waves which carry a small amount of energy inside them. They are electromagnetic waves. Okay, so what happens is that when these oscillating magnetic fields, they come in contact with the energy of the radiation, what happens is that their spin changes. Okay, so they basically start spinning in a flatter sort of axis. Okay, so this spinning is known as precession. Okay, now as long as the energy from the radio frequency waves is being bombarded on it, it will be spinning at a different angle, so to speak. Okay, so when the bombardment stops, okay, then this again tries to come back to its original precession slope, you can say. And during this change of the precession, during this change of the direction of the movement, the energy is released back in form of further radio frequency waves. These then get caught by the sensors in the MRI, and these are converted into images. Now, the sequences which are generated are based on many different characteristics of how the energy comes back. Okay, so the energy usually comes back at a rate which is sort of exponentially reducing. So this initial sort of energy is used to construct the T1 images. Along with that, what happens is that this energy emission is not constant. Okay, so there is sort of like when these come back, okay, to their original, they also interact with the nearby protons, okay, which are also oscillating in that sort of fashion. Okay, so that creates some inhomogeneous effects in how it comes back and how much energy is released, etc., etc. Okay, so this leads to a form of another form of radio frequency waves coming out, which is known as an echo. Okay, so that is used to that is again modulated by further bombardment, etc., etc. Many things happen during that. The bombardment can be in a specific rate, which is called a gradient sequence, and or it can happen at separate intervals, which are continuously prolonging, or it can happen at different phases. Okay, so there are many ways in which it is this radio frequency information comes back, okay, and the bombardment happens. So that is used to construct the T2 images and further other type of images, which we will see in the in this video. Okay, so this is just the basics. You don't need to remember any of this. Just remember that it's all because of protons, and the protons' magnetic fields are affected by the magnetic fields nearby to them, that is the nearby protons, as well as it is affected by the magnet of the MRI, as well as it is affected by the radio frequency waves which are bombarded on it and in a specific sequence. Okay, now let's come to the practical parts of it. What are the basic sequences that are useful for you? Okay, so the first sequence that you will come to here is called the T1 weighted sequence. Okay, the T1 weighted sequence is something in which fats appear bright. Okay, just remember this. T1 means fat appears bright. Proteins will appear slightly less bright, and water will appear black. Okay, so that is the only thing that you need to know. Okay, now that is obviously useful when you want to see some tumors, okay, in which there is a high cellular density. Cellular density means there are cell membranes which contain fat, which, so that appears a little brighter. That is slightly hyper intense compared to the other parts of the brain. Okay, so that is your T1 sequences. T2 sequence, let's just go over basics of each of the sequence, and after that I'll show you the images. The T2 sequences are those in which your water appears bright white. Okay, water is white. Okay, in T2 sequences, that's what you need to remember. So your CSF will appear bright white. Any edema will appear brighter than the other parts of the brain. A cyst which has got proteinaceous fluid inside it, but there is fluid inside it, that will also appear white. So whatever has water will appear white in a T2 image. Okay, now the problem happens that many times the parts of the brain that you want to see which have edema are close to the CSF, which is also bright white. So it is a little difficult to see those parts of the brain properly. Okay, so to improve upon that, there is a form of T2 which is called FLAIR. Okay, that is fluid attenuated inversion recovery. That's the full form. You don't need to remember that. Just remember FLAIR images. FLAIR images are a form of T2 weighted in which the pure water content, that is the CSF, is suppressed, and anything else which contains water but is not pure water, okay, that appears bright. Okay, so edema is very well observed in FLAIR images. And this is the first sequence that you should see while seeing any of the pathologies that you want to see, whether it is tumors, whether it is stroke, any of those. First see the FLAIR image. Okay, that will give you an idea about where the edema is. Okay, after that you can go ahead and see the other images, but FLAIR is the first one that you should see clinically. Okay, now let's come to the next sequence, important sequence, that is called susceptibility weighted imaging. Okay, susceptibility weighted imaging means that that consists of three different sequences which are mishmashed together to give you the SWI image. Okay, now you don't need to look at the three of the other sequences which are mishmashed together. They are also present in the list of the sequences that will be given. They are called MIP, MAG, and phase images. There are three separate images which are produced, and all of them are mishmashed to form the SWI images that you will see. The SWI sequence is useful to observe any form of paramagnetic or diamagnetic substances inside the brain. Okay, now the paramagnetic and diamagnetic substances mostly are minerals. So the useful minerals that you will be able to observe in that are deoxyhemoglobin, that is small collections of blood, that is microhemorrhages. So deoxyhemoglobin, very nicely seen, it appears dark black. Okay, next, ferritin, hemosiderin deposits, that is usually present in the substantia nigra, so that also appears slightly blackish compared to the rest of the brain. Your veins, they will have deoxyhemoglobin, more concentration, so and arteries also will have some bit of deoxyhemoglobin that will also appear blackish. Okay, and lastly, your calcium deposits will also appear deep black in SWI images. So that is useful for seeing calcification within tumors, microhemorrhages within tumors, microhemorrhages in the parenchyma of the brain, etc., etc. Okay. Also, your pineal gland and your the normal structures which are calcified, the choroid plexus, their calcification will also appear dark black in SWI images. Okay. So that is about SWI. Next comes a special type of images in the MRI, which are more useful for stroke and few other purposes, that track the water movement inside the brain. Okay, now we are coming to the diffusion images. Okay, so the first image that comes to you from the MRI side is called diffusion tensor imaging, DTI. Okay, I'll show you what that means. Okay, but DTI is basically a form of imaging in which individual protons inside the water, okay, of the brain, their movement is tracked. Okay, so each voxel will contain like millions or billions of small protons of the water which will be moving somewhat. Okay, and the movement will be tracked in milliseconds. Okay, so that movement can happen along any direction, right? So the direction is broken into x-axis, y-axis, and z-axis. Okay, so it is broken into 3 axes, and the movement, the magnitude of the movement in each of those axes is tracked, okay, and quantified. So this type of imaging in which the movement of each individual water molecule along different directions is tracked and quantified, that is diffusion tensor imaging, DTI. Okay, the another name for that is, I think, anisotropic diffusion imaging. Okay, so anisotropy basically means that you are seeing it in different directions. Okay, after that, the next thing that happens is that all of these in the 3 axes, the magnitudes, they are averaged out. There's a geometric mean that is taken of these. Okay, so that geometric mean gives you the isotropic, meaning that you have nullified the effect of the directions and all you're tracking is the overall diffusion of the water molecule. Okay, so this is called the diffusion weighted images. Okay, so first comes DTI, in which there is direction and magnitude. Next comes DWI, diffusion weighted imaging, in which the magnitude is preserved, but the directions don't matter. Okay, so only how much movement is there is tracked, or how less movement is there is tracked. Okay. Lastly, from these DWI voxel intensities, certain mathematical calculations that are done to get a diffusion coefficient, which is called apparent diffusion coefficient, or ADC. Okay, so that has some special properties that we'll discuss a bit later. It will come useful in stroke. Okay, now how do these images look? I'll just give you an idea before so that you have an idea. After that, we'll see the images. Okay, so in the diffusion tensor imaging, you will be able to track the water movement in the white matter. In the white matter, what is there? There is axons. So across the axons, inside the axons, water movement is happening in a linear direction. So that is tracked. So you will be able to see in which direction your axons are moving. Basically, the axons are present in which direction. And that will be separated by color gradients into X, Y, and Z axis. So, and that colorful type of image is your DTI. Okay. DWI is, in DWI, anything which has a diffusion restriction, meaning that water is not able to move much. Okay, that will come under DWI, and sort of the mirror of that, meaning whatever is bright or diffusion restricted in DWI will usually come black in ADC. Okay, these have a few properties which change over time in stroke. I will talk about it when we see the images. Okay, so this is your DTI, DWI, and ADC. These are the three important sequences that you should know about. Next, the last sequence that we'll talk about is a special version of the T1 images, okay, in which your gadolinium is added, and it is a very highly detailed type of image which is called MP-RAGE. It is a version of the T1, okay, in which mostly gadolinium is given, so you'll be able to see the arteries very well, and in that fat will appear bright white, and rest of the brain will appear similar as T1 images. Only thing is that it is highly detailed, meaning that you will be getting sections at every millimeter. So you'll have huge number of slices to go through, and you'll get very detailed view of the anatomy of the brain as you go from bottom to up. Okay, so when I try to teach my students, the MP-RAGE images are the best images to observe normal anatomy because they are highly detailed and it looks very beautiful. Okay, you'll be able to make out the structures very nicely in a T1 MP-RAGE image. Okay, now having described all of this, let's just go to see how these look in an MRI. Okay, now I'm sharing my screen. Sorry, entire screen. Okay. So in this, you'll be able, so this is a video that I took of a patient who is suffering from status epilepticus. Overall, the brain anatomy appears to be normal. So this is just for showing you the way the images look. It's not about the pathology. Okay. So first we are starting with your T2 images. Okay. So in the T2 images, let's just scroll through it. You'll be able to notice that the arteries appeared nicely black, and the CSF, you can see the cisternal spaces with CSF inside them. They are all appearing bright white. Okay, let's go. So here you are able to see the cisternal spaces, and here you are able to see the temporal horn of the lateral ventricles, which is also appearing bright white because it has fluid inside. Third ventricle, the posterior horn, and then the lateral ventricles themselves, as well as you'll be able to notice that the sulci which have got CSF inside them are also appearing bright white. So this is how your T2 images look, in which water is bright white. Okay, and sometimes around the edges of this ventricles, there will be some periventricular edema. That will not be very apparent when you're looking at T2 images because the CSF itself is bright white. It forms everything else. So that is why you need flare images in which these are not present and only you're able to see the edema inside. So that I'll show you in some other sequences. So let's just move ahead from this. Okay. Now I'll be showing you the SWI images. Remember, the susceptibility weighted imaging, SWI, has got mineralization deposits which appear black. So your arteries and veins containing deoxyhemoglobin, your microhemorrhages which contain deoxyhemoglobin, your substantia nigra, red nucleus inside the brainstem which contain ferritin and hemosiderin, and lastly your mineral deposits of calcium, okay, which can appear inside the tumor, which can appear in sites of gliosis of old trauma to the brain, or which can appear normally in your choroid plexus and pineal gland. Okay, so they all will appear black, okay, dark, deep black. So let's just go. Okay. Are you able to notice these? These are the substantia nigra and this is the red nucleus. They are appearing black. Okay. Are you able to notice this blackness? This is basically your calcification inside the choroid plexus. Unfortunately, in this patient, we do not have any calcifications or any other mineral deposits that I'll be able to point to you. So because of that, I'll just leave it here. Okay, so this is how your blackness, your microhemorrhages will also appear. They will appear as deep black. Okay, so I'll just continue on. Okay, so in this, okay, this is done. That's all. Okay, let's continue on. Okay, so this is the ADC map. There is nothing very special in this. I've just shown this to like give you an overview of how it looks. Okay, we'll skip these parts. I'll show it to you in much more detail when we look at the stroke. So after this, there is some diffusion weighted images. So those also I'll skip for now. So this is something which will be useful for you to understand. So in this, you are able to see that this is basically the colorful image of diffusion tensor imaging. Okay. So in this, I always get confused about the color codings, but it is easy to understand once you know anatomically how your tracts usually are in the brain. Okay. So you can see this red colors. So these red colors are the colors at the corpus callosum. In the corpus callosum, you know that the fibers are going from one side to the other side. So this axis, okay, it is color coded as red. Okay. Next, you are able to appreciate the internal capsule here. So these internal capsule contains the corticospinal fibers. Corticospinal fibers go from cranial to caudal. So basically cranial to caudal like this. So they are color coded as blue. So the only other axis left is posterior to anterior, anterior to posterior. That is color coded as green. So once you have understood these color codings, you'll be able to make out, okay, the white matter fibers are moving in this direction and the movement of water inside is this much based on the intensity of the color inside it. This is not very useful for us. Frankly speaking, it is more useful for the surgeons to know, like if there is a big tumor, okay, which is near white matter tracts, important white matter tracts like your corticospinal tract. Okay, so they will be able to know how the fibers have been displaced, in which area the fibers are before they go in, so that they are able to avoid that area or at least use some neuromonitoring to know that, okay, this is where the fibers are. I need to avoid this area to prevent damaging the internal capsule, and so on and so forth. It can have utilities in that fashion. For us, it doesn't have practically much utility. Okay. I'll just play it for you just to give an idea. Okay, so here you are able to see this is a mix of red and blue, purple basically. Okay, so remember your red was side to side fibers and blue was top to bottom, that is cranial to caudal. Okay, so that is, so here basically there is a mix of fibers of both of those types. Here you are able to see these tracts are going anterior to posterior because they are color coded green. Okay. Here you are able to see the corpus callosum, which is color-coded red, the internal capsule, which is color-coded blue. And this is also a part which is going down. I'm not very sure which track that is. But yeah, so that is how it generally looks. So again, this is the corticospinal tract, which is going to go down. Okay. So this is how it looks like. It's like a pretty image, not very useful for us, frankly. Okay. So beyond this, in this sequence, I'll be only showing you the T1 weighted images after this. So this is what the T1 weighted MP-RAGE images look like. Okay, so you'll be able to notice that these images are pretty detailed because like they are very thin slices. Okay, and you will be able to notice the blood vessels, the anatomical structures, everything very beautifully in this. You can see these two vertebral arteries coming in front of the medulla. Then they'll join to form the basilar in front of the pons. And you are able to notice the sigmoid sinus very nicely, very beautifully. And you can see the detailing of the cerebellum, the brainstem, everything is very nicely seen in this. So this T1 MP-RAGE image, gadolinium enhanced, is very useful for tumors as well as understanding the normal anatomy. Okay, so I will request all of the residents to please go through the MPRAGE images of a few successive patients to understand the normal anatomy of the brain and how the arterial architecture is like and how the other structures of the brain is like, because this is the one in which you will be able to see it very beautifully. Okay, so you are able to see the tentorium very nicely. You are able to see the transition between the posterior fossa, cerebellum, the striations of the cerebellum to the temporal lobes here on the sides. You're able to appreciate the brainstem very nicely. You are even able to see the aqueduct of Sylvius here at the bottom. Okay, you are able to see the MCA starting out from the ICA, the ACA here. Okay, you are able to see the the posterior cerebral artery looping around the midbrain. So there are many beautiful details that you'll be able to make out from this. And this is very useful, especially for tumors in which contrast enhancement is there or not there, or any other pathologies which have something specific on contrast enhancement or just for normal anatomy. Okay. So this is your T1 MPRAGE image. Okay. Now I will stop this video for now and the video that I was showing, and I'll go to a few pathologies that are interesting. Okay. So this one is like, this is from Radiopedia. Okay, because I don't have actual images of many of patients with pathologies right now. So I'll be taking examples from Radiopedia. In this, you are able to see that there is a hypointense structure in the cerebellum. Okay, on axial T1. Okay, remember on T1, fat is bright. Okay, your proteins are less bright and water is least bright, basically least intense. Okay, so in this, you are able to see one circular structure which is hypointense compared to the normal surrounding brain. And in the temporal lobe also, you are able to see a similar round structure. Okay, so and here in the posterior, the parietal lobe also, you are able to see a similarly rounded structure. Okay, now let's see in the T2 images. T2 means, remember, T2 means water is bright white. Okay, and that's it. Okay, so here you will be able to appreciate edema, or you'll be able to appreciate fluid collections. Okay, or fluid mixed with protein collections also. Okay, so as we go, so this is the posterior parietal one that I was showing you before. You can see there is some perilesional edema, and inside the lesion also it is whitish compared to the rest of the brain. So it is hyperintense, so it contains water. Okay, that's what you get from it. Okay, you can see the CSF is obviously bright white. You can appreciate the edema in the temporal lobes here. Okay, not temporal, posterior parietal and temporal lobes. Okay, you are able to appreciate the edema very nicely because it is bright white compared to the rest of the normal brain. Okay, let's go down. Sorry, let's go down. You are able to appreciate again a circular structure in the temporal lobe with surrounding edema, which is white, and inside also it is white, meaning that it has got some sort of water content inside it. And lastly, the cerebral lesion also has water content inside it, because of which it is bright white. Okay. Now let's go to the FLAIR images. In FLAIR images, remember it is fluid attenuated. So your CSF, pure water, will be black. But rest of the protein mixed water will be, or edema basically, will be white. Okay, so let's look at the FLAIR images of this one. So you can see that inside has become blacker now compared to before. Okay, so this does contain a bit of water. Okay, you can see there is surrounding edema which has become white. Okay, now let's go up. You can see that the edema is showing up very nicely now compared to the rest of the brain. And inside these cyst type of structures, you are able to see that it is hypointense now. So it does contain a fair amount of water inside it. Similarly, in the posterior parietal lobe, also you are able to see a similar sort of finding. Okay, so now you are understanding the importance of FLAIR in which edema is visible very nicely. Okay, now let's look at the DWI images, or the diffusion restricted images. In diffusion restricted, in diffusion weighted images, sorry, the areas which have got diffusion restriction, meaning that water is trapped. Okay, Trapped basically means that water is not able to move. That's all. The water will not be able to move if it is densely packed because of protein around it, or it is trapped inside cell. Intracellular water will appear bright white, while the outside cellular water, the intercellular water, which is able to move, will not appear white. Okay. Now, since the number of water molecules is huge inside each voxel of this image, it is basically an averaged value that you are getting. So in stroke, what happens? Initially, as soon as your ischemia starts up, your ATP depletes. ATP depletes means sodium channels stop working and water starts accumulating inside the cells. Okay, so compared to outside, inside intracellular water content increases. So that is called cytotoxic edema. Okay, so in cytotoxic edema, you are because the inside water is not able to move and it is more compared to the outside water, then it starts appearing bright white in DWI images. Okay. Similarly, in any condition in which your water is not able to move, there DWI will show you a bright white image. Okay. So here you are able to notice that posterior parietal one is bright white, meaning that it has water inside it because you confirmed that in the T2, but the water is not able to move. So why inside, like normally when water is in a space where like CSF, okay, like inside the ventricles, it freely diffuses, okay, because of which there is, it will appear black on DWI, it will appear black on FLAIR also because it is pure water, okay. Now in the FLAIR images, you saw that it was hypointense, but not completely black like the CSF, okay. So that tells you that it is water mixed with something else. And water mixed with something else and the water not being able to move inside the cavity, okay, that tells you that there's a true restriction happening of the water movement there. So that basically means that it is something like an abscess in which it is tightly packed water with proteins and fats and everything mixed together, okay, and the water is not able to move anywhere else. Okay, so that is diffusion. That is how an abscess looks on a MRI scan with which you deduce from multiple images together. Okay, so you will be able to see diffusion restriction inside these. As we go down inside this, you are able to see the diffusion restriction. Around it, you are seeing a blackish type of area where water is freely able to diffuse. The edema areas where water is freely able to diffuse. But inside this, it is appearing bright white because it is not able to diffuse. Okay. Similarly, your CSF and all will be black because their water is freely able to diffuse. And the cerebellar one also bright white. Okay, so our conviction that this is a abscess, cerebellar abscess increases now. Now looking at the inverse of that, sort of inverse of that is the ADC maps in which your diffusion restriction will appear black compared to the rest of the brain. So this basically confirms what is happening here. Diffusion restriction inside, diffusion restriction inside, outside it is freely able to diffuse, and here also diffusion restriction inside this cyst type of structures. Okay. Now, we have already seen the T1, so I'll not be going for sagittal and coronal T1. I'll be going to the SWI. Okay, the susceptibility weighted images. In susceptibility weighted images, remember, it's all mineral deposits, specifically deoxyhemoglobin, hemosiderin, ferritin, calcium. Okay, these will appear black. Okay, so you are able to see the red nucleus and the substantia nigra in the midbrain here. Okay, and okay, in this you are nicely able to see the pineal gland which is calcified, the choroid plexus which are calcified. Okay. That is it actually. In this, like you can make out that inside these edematous areas or inside the lesions, there is no mineral deposits. That's all you are able to make out from the SWI images in this patient. Okay, so that is how you read the MRI. Now let's go to one more. This is a case of stroke in which I'll be showing you how diffusion restriction looks, how it will look on FLAIR, etc., etc. Along with this, there is one important fact that you need to understand. Okay, your stroke or the movement of water inside and how it looks on the MRI evolves over time. Okay, in acute stroke. Okay, in acute stroke, meaning that it is around 1 to 3 days approximately. Okay, in that time, your DWI will become bright white within a matter of minutes, meaning 15 to 20 minutes, and your DWI will become bright white. Okay. ADC will start showing in a while. It will not show immediately, but in a span of few hours, your ADC values will start becoming black in a stroke patient. Okay. After that, what will happen is when it becomes a subacute stroke, meaning that it is more than 3 days up to 7 days or 7 to 14 days. In that time zone, from acute to subacute, during that time, the DWI will stay bright white. Okay, like the DWI basically increases and then it stays bright white. Okay, but the ADC, which had become black, will start becoming whiter. Slowly, it will start becoming whiter as the time passes. Okay. Now, when it starts becoming chronic, that time, like even more time has passed, that time your ADC values will shoot past the baseline values that were there. It will become even more whiter. And your DWI values will start coming down, and then they will go down to normal. Okay, so that is how your changes happen. Let me repeat it. ADC values increase within minutes. Sorry, DWI values increase within minutes, stay constant, and in the chronic phase start reducing like this. Okay, the ADC values will be a little slower to respond than the DWI. They will become black in a span of few hours. Okay, that is basically confirmation of an acute stroke. After that, they will start rising, and they will rise beyond the baseline towards the end of the chronic phase. Also, as it becomes more chronic, this phenomena of ADC becoming more brighter is a phenomena which is because of which is called T2 shine through, meaning that water content basically starts becoming more and more white. Okay, and this will start showing up as sort of edematous areas or white areas on the FLAIR images also. Okay, FLAIR and T2 images also. So that is how a chronic stroke will look, where you have got white white T2 FLAIR, white ADC, and black DWI. That is chronic. In acute stroke, you will have the DWI being bright white, ADC being deep black. In the middle zone, you will have DWI, which is still bright white, but the ADC is little less black. Okay, so that is how the stroke, the MRI images in stroke evolve over time. Okay, now let's just look at this one. This one is a case of acute stroke. So let's start with the DWI and ADC and then go on to the other one. So in the DWI, this is the DWI images. Are you able to notice this general whiteness in this part of the cerebral hemisphere compared to the other hemisphere? So this is the part which is undergoing stroke. Okay, so this is basically your DWI showing whiteness. Okay, then the same thing in ADC is visible much more. You are able to see the blackness in one hemisphere compared to the other. So this person has suffered a MCA as well as ACA infarct. MCA as well as ACA infarct, basically an ICA, hemispheric infarct on the right side. Okay, this infarct is acute because DWI is showing white and ADC is showing black. Okay, if you look at the same thing in FLAIR images, you'll be able to recognize a general whiteness, but it is not bright white. Okay, but apart from that, are you able to notice this white patch here? And also, as you go down, actually there is nothing else in this. There are small patches of white here. Okay, so these are all chronic strokes which have happened in the past. Okay, on the other side. Okay, so this is how it will look in a chronic stroke, where there'll be almost nothing shown in the DWI. You can see there is nothing else in the DWI except for this side being white. On the ADC, this part is not showing much. Okay, you can see a little bright white zone here. This is also the part of the T2 shine through which is happening. Okay, but you're not able to appreciate much. On the FLAIR image, you will be able to appreciate the old strokes much better. And in this, you can see there is some general whiteness. This is the area where your watershed zone of MCA and ACA are. So this area is showing a general whiteness. This can be old watershed infarcts that have happened in the patient. Okay, but the acute infarct of this hemisphere, entire hemisphere, is not showing on FLAIR right now. It will start showing after 3 weeks or so. Okay. Along with that, one more small thing that I want you to notice is this periventricular edema is being shown very nicely in the FLAIR image, which will not be very apparent in the T2 images themselves. Let's look at the T1 images. There's nothing of note in the T1 images. You're not able to make out anything in this. Okay. T2 images, you are able to make out a bit of edema here compared to the other side. Okay. But that has gotten attenuated to quite an extent in the FLAIR images. Apart from that, these old infarcts you are able to see. And that's it. So if you are seeing this FLAIR image as a the T2 image as a slightly whitish, that basically means that it's not a very acute stroke. That means that it is like slightly more than 3 days or 4 or 5 days old stroke, which has happened because the T2 is starting to shine through. Okay. So this is not a completely acute stroke. This is like early subacute stroke, which is being shown in these images here. Okay. So this is about stroke. Lastly, okay, I think I have covered most of the details. Few specific details about related to tumors and all that. Like it will take a long time to show each and every type of tumor, which have different type of characteristics, hyperintense in this, hypointense in that sequence, etc., etc., that you can read up on your own. Lastly, I would like to show a bit of research that I had done during my DM time. Okay. So in that, I had tried to quantify whether blood loss during a surgery from a tumor can be predicted based on MRI images. Okay, so basically based on MRI characteristics of tumors, whether I can predict the blood loss which is going to happen in the surgery. So this didn't get published. I didn't try to publish it also, frankly speaking, but I just wanted to share the results because they are useful for you when you are doing getting surgeries done. So in this, I had this was a retrospective study. So I had basically estimated the blood loss using these formulae here, in which estimated blood volume, hemoglobin pre to post, and how much blood was given intraoperatively. All of that was calculated, and it arrived to a blood loss per person value. Okay. Along with that, the tumor characteristics that I had focused on was first size of the tumor. Obviously, larger tumor may mean more blood loss. Who knows? Proximity to venous sinuses. Closer the venous sinus, more is the chance of blood loss. Proximity to major intracranial arteries. Again, closer to arteries may mean more blood loss. Pattern of contrast enhancement. So this is something that is a little interesting for me to see, because many of the residents that I interact with, they somehow equate contrast enhancement with blood flow inside a tumor. Okay, it is not that. Okay, understand that contrast enhancement will only happen if your contrast leaks into the brain tissue or the tumor tissue. If it is only confined to the blood vessels, it will not show up as a diffuse enhancement in the MRI. Okay. Contrast enhancement will only come if it diffuses across the arteries at arterioles or capillaries into the brain tissue, and there you will be able to see it as a bright white. Okay, so that will happen only in cases in which your blood-brain barrier is not intact. Okay, so contrast enhancement is more equated to blood-brain barrier integrity than it is to blood supply. Okay, obviously, if blood supply is not there, it will appear black. Okay, it will not have any contrast enhancement. But presence of this contrast enhancement doesn't mean that blood supply is more. It just means that that area has a poor blood-brain barrier. That can happen in relatively less vascular tumors after radiation therapy. Okay, it can appear it can appear in poor grade gliomas, intraxial tumors, which are poorer grade. Okay, because there is a lot of neovascularization happening, blood-brain barrier is not intact, and because of that, it leaks out. Similarly, in good grade gliomas, it will usually not be contrast enhancing. Okay. Lastly, meningiomas, which are like extra-axial tumors, which do not have blood-brain barrier, will always appear brightly enhancing. Schwannomas will also appear brightly enhancing because they are not of the brain. Okay, they don't have a blood-brain barrier. Okay, so always equate contrast enhancement with blood-brain barrier. So here I was trying to look at the pattern of contrast enhancement, basically as a sign that the tumor is a poorer grade or a good grade. Or intraaxial versus extraaxial, both the conditions are met in this. So whether it is non-ring enhancing, patchy, or homogeneous enhancement, just to see whether it can be correlated with your blood loss or not. Then suspected histopathology of the tumor, that will be based on the MRI report. Okay. Percentage of areas of hypointensity. So of the total area of the tumor, how many patches were hypointense, meaning that they had necrosis. Okay, that's what I equated the hypointensity to. So that was one thing that I wanted to see. Again, that is poorer grade or good grade tumor. Average pixel intensity of SWI images. This I don't really, and this actually means microhemorrhages. If there are more microhemorrhages, it will appear, the overall average intensity will be on the lower side compared to other tumors which do not have microhemorrhages inside them. Okay. Then the number of flow voids within the tumor. This is one point I missed in FLAIR images, especially in tumor surgeries. In the FLAIR images, your blood vessels will appear as black. Okay, so you will be able to notice the blood vessels as black regions, which are called flow voids. Okay, so the number of flow voids within or around the tumor means that there is more blood vessels within or around the tumor. Okay, so I also tried to equate number of flow voids, meaning more number of vessels inside the tumor, with blood loss. And lastly, your peritumoral edema, whether the edema was more or not, that again, good grade versus poor grade, etc., etc. Many reasons why maybe peritoneal edema is associated with hemorrhages. No, sorry, blood loss within the surgery. So in this, I will just zoom in on the results. Okay, here I'll just point out the interesting things, and after that I'll let you go. So the interesting thing was obviously tumor size high. It is quite nicely correlated with the amount of blood loss that is expected. This is something that I had not expected, and it was very interesting finding that there was a negative correlation between percentage of necrosis within the tumor with the blood loss, meaning that more the necrosis, less is the blood loss. So poorer grade tumors in which the growth has happened so explosively that the neovascularization has not been able to keep pace, and many of the parts of the tumor are dead. Okay, do not have blood supply. That basically means that they will not have as much blood loss because not much neovascularization has been able to happen in the past. Okay, then number of flow voids is positively correlated. More the number of flow voids, more will be the bleeding during the surgery. Contrast enhancement ratio didn't have anything to do with the bleeding. It was not significant, as you can see. And your pattern of contrast enhancement. Okay, in that your what was the number 4? Okay, I think this is the homogeneous enhancement. So the homogeneous enhancement had a stronger association with your amount of blood loss. And I think this has happened because homogeneous enhancement is usually seen in meningiomas. Okay, then proximity to rest of them, proximity to blood vessel, venous sinuses, and edema didn't have any connection with the blood loss. Lastly, your tumor histology, your meningioma suspicion had a much higher blood loss. Obviously, meningiomas bleed more. And also tranexamic acid used during the surgery also was associated with bleeding, but that is a reverse type of effect that you give Tranexa in those cases that you expect it to bleed, right? Otherwise, you won't give Tranexa. So it is not a causative, it is more of an observation that Tranexa use is obviously more in patients where bleeding is expected. Okay, so with this, I will let you go. Okay, most of the information that I've derived has come from Radiopedia. It's a online resource for MRI, CT, any radiological imaging, and even DSA. Please go through those. It will be very useful for you as residents to learn what all different sequences mean, what all different types of things are seen in different types of images in different conditions, etc., etc. Okay, so with this, I will let you go. Thank you for listening, and have a nice day.